Hey, everybody. Welcome back to Telemedicine Talks. This is Leo and Phoebe. Hello again. And it's about that time, it's
Hey.
at the end of the month. And we are going to talk about kind of interesting things in the months and updates. All right, Phoebe, you're the best at this.
From my perspective, like July was kind of interesting. There's like a hodgepodge of different interesting kind of topics in the digital health space and compliance space and just like enforcement space. So, one of the things that I thought that was super relevant, and I know, Leo, we've done a podcast about the one big beautiful bill already,
Yeah,
but
yeah.
there's a lot of stuff that's kind of tied to government.
Big, beautiful
And
bill.
one
Love it.
thing that I thought was pretty interesting is it is called the Wiser Act, Wasteful and Inappropriate Services Reduction Model, which is this new pilot that the Centers for Medicaid and Medicare are launching in some select states, basically to use AI and machine learning to ultimately, like, audit companies in real time. So it's going to basically how is billing looking? Then it's gonna, like, flag outliers, or that's kind of, like, my guess. They're obviously not saying exactly what they're looking for, but from a regulatory standpoint, like, as, an ex-regulator, like, that is to me what is probably gonna happen.
So they're basically using AI as instant regulators, right?
Yeah, in real time, basically. So they're looking for overpayments, they're looking
Yeah.
for upcoding, they're looking for anything that kinda looks off. I think they're also looking for overutilization. So one interesting thing as I was scouring enforcement this month, there was a case around genetic testing, and this one company had claimed to do, like, I don't know, 3,000,000 genetic tests, or oh, sorry, it wasn't genetic testing, it was catheters. And basically, when the regulators looked into it, they were like, "The company couldn't even produce 3,000,000 catheters. So, like, how did we not catch this sooner?"
Huh.
And so I think it's looking for things like that, where if you have something running that's able to, like, flag some of those almost, like, obvious fraud cases or obvious, kind of like overpayment. I think that's what it's looking for.
And so it's just looking for outliers, right? Just using AI to do so.
Yeah, so there is still gonna be, like, a human element to it. So, when I would do this work, you have a whole team that is kind of
Yeah.
looking for these outliers. I would get my report of the outliers, and then from those, I would decide what are the ones that we're gonna go investigate. And so this is just ridiculously speeding up that process and putting it on, like, a way, way, way larger scale to where instead of looking at a sample size, they're looking at everything.
Yeah.
And I think the biggest thing here is it doesn't matter if it's big, small, if there's any discrepancy, I think you're gonna be flagged for some sort of non-compliance or some sort of audit.
Yeah, so that's interesting because you're right. We already know AI speeds everything up, right? Things that, especially analysis, um, big, large amounts of data, it has cut our workload and the time and turnaround into fraction of what it is before, right? And speeding everything up. And so this is just a natural progression into that. But it's going to be interesting to see how they use it and how they regulate the regulation too. Because one of my big questions is what kind of algorithms, what kind of data are they using to flag what is actually waste? And yeah, there's obvious ones, right? Like the 30 million catheters that they really can't make, or like billing discrepancies or these big patterns of billing where maybe a practice is billing higher, higher billing codes and just like, that's just way out of the blue. But when you get to, question is, are they going to delve a little deeper into kind of on the fence and how deep are they going to do this? Personally, I think it's a great idea. I think it protects our money and whatnot. But yeah, that's one of my big questions is, are they going to be very transparent in what criteria they use or not? I hope they are.
They're not gonna
Probably
be.
not. Right?
But, like,
Daydreaming.
you I mean, you have to also understand, right? Like, all these rules and regulations are they're there. So anybody who's doing these services needs to understand what these rules are before they start, right? So the
Yeah.
assumption is like, you're doing this today, you better be doing it correctly. And if not, we're going to catch you. And I wouldn't give out my methodology behind the scenes of how I'm actively, monitoring people, because then you're going to kind of know what you can potentially like get away
Yeah.
with.
Yeah.
So, I mean, in some realm they might, but like most of the time they're probably not going to. And kind of like what you said, I mean, I think it's going to be something that's going to be a work in progress, because like this is what you would call like a basic like rules engine. You're going to need to build something super robust that ties all those rules, those complicated rules, how you interpret those rules, how the federal government interprets those rules versus like the lay person. I mean, this is why companies hire me, is because they can't understand that language. That's going to be the interesting discrepancy, right? Like you're going to be like,
Yeah.
no, no, I'm totally compliant. And it's not. So, I mean, either way, I think so that the pilot is starting in 2026 and it's going through the end of 2031 in some select states. And this kind of segues into like my next topic a little bit, but I think they're doing this now on everything,
Yeah.
because there has been such a huge uptick in enforcement and overpayments that, in my opinion, don't warrant the normal thresholds for overpayments, that like the federal government is watching already and already has some AI tools supporting monitoring now.
Yeah. And do you think they use this tool during that big crackdown as well, recently?
I don't think so. I mean, the crackdown, all of that investigation, I think that was all stemming from the Biden administration. So that was all stuff that actually
Mm.
had been in the works for probably over a year or so. But I do think the idea is every year a crackdown like that is going to happen, and it's just going to get bigger and
Yeah.
bigger, especially as this administration has said fraud, waste, and abuse is like number one
Yeah.
on
Yeah.
their radar. And I met with a client this week who was talking about like overpayments. They had a question, they got an overpayment notice from Medicare, and they're like, "Well, we can't believe it because it was such a small amount." And that's kind of where, like in my head, I'm like, normally overpayments are usually like in the 25K
Yeah.
realm. Like you're looking at like a certain number. And it's pretty apparent that they don't care if they've overpaid you by 2 pennies. Like, you are going to get a notification that you've been overpaid, and you are going to have to pay that back.
Yeah. Yeah. And this is just going to make it more efficient, right? So you're right. Things that would have taken years to do it now will take fractions of days, weeks, maybe even days, right? So
Yeah.
no, that's totally interesting. And trying to relate it to the telemedicine space, right? We're going to see probably a lot more scrutiny and a lot more, these high volume virtual services, especially the niche services that prescribe over and over again, especially if they deal with Medicare and Medicaid, the federal programs. They're going to be under the microscope. Why is this one service prescribing, a proportionally increased number of birth control versus not, things like that. Also, the coding practices as well. So, yeah, these companies, if you're starting to work for these companies, definitely understand how they code and how the payer mix is. So, yeah, if push comes to shove, you could back yourself up. Be like, hey, I think better understanding. Personally, I think when I started, I was kind of glib, but just like, hey, okay, I trust the companies, which, I think I've stuck with the companies that I could trust in terms of compliance, right? Because I've delved deeper, but this would have been way useful to know about when I was starting out. Better understanding versus just almost kind of the wild, wild west before.
Yeah, 100%. I mean, again, I think it's that you're thinking about the same services that I think are kind of rife for fraud. So DME is, of
Yeah,
course,
yeah.
gonna be like, I mean, yeah, if you're a DME provider and you're doing anything that is like slightly like questionable, like, oh my gosh, like, please stop. Go
Oh,
look at
yeah.
the OID. It's all freaking DME. RPM is CCM,
Genetics,
genetics,
right?
labs. Still COVID most of the time.
Right.
So again, I mean, I think this is actually great. Companies are gonna hate it because you're getting that real-time oversight, but from, my stance of having to do this stuff, I think it's gonna be great. It's gonna clean up a lot, and I do think it's gonna reduce a ton of I don't wanna say fraud, but I think it's gonna potential fraud, but also just,
Yeah.
like, some initial mistakes that people are making that honestly you don't realize because you get audited 3 years in, arrears, and then you're like, "Oh crap, I've been overpaid all this
Right,
money."
right.
So again, I think it's just gonna really help providers do things the right way too. But yeah, I thought that was a really cool update.
No, that's interesting to see and interesting to watch. And this, you said it's starting next year, right? With some pilot states and going further if it works out.
Yep.
That's yeah. So we'll see how that goes and how that shapes really medicine in general. Cool. Let's see. So one thing that I thought this is still going. I think we kind of heard about it late last year, which I thought was interesting, was this legal clash between this doctor in New York that prescribed abortion pills for a patient in Texas, who, as you know, is one of the strictest anti-abortion laws, right? And doesn't allow almost any type of abortion. I don't know the specifics, don't quote me there, but I know that, yeah, they are one of the strictest, right? And they have threatened legal action, like severe legal action against doctors in their state, but also doctors from other states that are helping patients that live in Texas. So what happened was this doctor in New York prescribed birth control medication, pharmacy pills to a patient in Texas, and now Texas is going after the doctor legally. And Texas actually passed a judgment against this New York doctor, but New York is refusing to cooperate with the Texas order. So, you have the state to state fight. So it's interesting to see the back and forth between the states, the different rules, and how people are trying to push the literal borders of telemedicine where they practice. And what's the argument there? What was the thought there? Because, well, you are prescribing for a patient in Texas and you're following these Texas laws, right? But it's interesting that, okay, Texas can, pass a judgment, but they can't really touch this person because they're in another state. How far can they reach if it's a state to state thing? Because it's not a federal thing, right? So, what's your thoughts on that?
Yeah, I mean, I think abortion access is just gonna be something that is going to be a very hot topic. I mean, there's a lot of states that have actually gone further than Texas and passed legislation around criminalizing doctors who do provide any sort of service. I think it's the interesting thing is, yes, you're a provider in New York, right? So you're doing everything that's okay, but you're treating somebody in
Yeah.
Texas where these things aren't allowed. And so I think it kind of begs the question of like, is that an illegal practice of medicine? Are you actually legally practicing medicine if we're not allowing that service? And so again, I think, you can not to take it away from abortion, but I mean, it's the same thing of like marijuana,
Yeah.
right? Like
Yeah.
in
Right.
California, like it's legal. In some states, it's legal. If you prescribed it in a state like Alabama, like no, the doctor is going to be kind of held liable for it. So I think that's the interesting case. And the unfortunate piece of it is luckily for the doctor, New York is kind of like supporting the physician and the physician's autonomy there. It doesn't change the fact that like text this is going to significantly impact that physician and
Yeah.
it's going to significantly, take time and effort and money and part of your reputation to have to get back on, track.
Licenses too, right?
Yeah,
Because
license
yeah.
it. Like, I wouldn't be surprised if this provider loses their Texas license,
Oh,
probably,
absolutely. It's probably gone now.
yeah, and then
Right.
the unfortunate thing is once you lose one license, you actually have to notify all the other boards,
Right.
so then it's
Right.
like, is Mississippi gonna take your license? Is Alabama gonna take your license? Is South Carolina?
Yeah.
All those other states that have similar ideas around abortion access, I think
Oh, hands
that's the
down,
thing.
they're gone. They're
Oh,
not gonna be
yeah.
able to practice in those states for sure.
Yeah, so it's gonna again, it politicizes medicine, which I think is the hard part of living in this world today as a non-physician.
And that's one of the main kind of arguments that this doctor was having why they did it and just went forward with it is just highlighting the politicalization. Can't say the word. Anywho, of medicine, which honestly really shouldn't happen. It should be apolitical. It should be above that. But unfortunately, as we see now already, right, there's definitely large implications with that. So yeah, that's again one of the big kind of major arguments that this doctor's highlighting. Pretty ballsy, I think. Sacrificing a lot of your practice for those primarily practicing telemedicine, that's a huge risk, right? Because, yeah, your licenses are going to go down.
Yeah. And I think too, another thing to just think about, like when you come to working as a physician in telemedicine, let's say you're working for a company. Was this person doing private practice, or was she working for a large telemedicine company that offered these services? I think those things are going to come into play. Like I know you're on some women's health platforms and or have in the past. And do you know if certain services are allowed or not? And I think that's another thing where it's like, gosh, like physicians really need to understand, sure, okay, I've been doing birth control or plan B or some of the other things, like, but are those things actually legal and are you going to get in trouble? And the question is, does the company that you're working for understand those implications? Do you understand those
Yeah,
implications?
yeah.
And could this potentially happen to you?
Yeah, no, absolutely. Definitely, it's a common theme there. Having an understanding of what you're signing on the line and what you're doing and what your company's doing on your behalf is key. Because, yeah, there's a lot of moving parts and especially crossing state lines. This is a good example of that.
Yeah.
Right.
So my next topic was a little bit about just like some state privacy laws. And there's been some lawsuits. You guys know I love talking about lawsuits, even though I hate lawsuits. But we're in America. That's what happens, I guess, here. California sued a really massive company. I don't know if anybody knows of Healthline. Healthline is like a blog company. So they share basic just blogs and information about healthcare and different services. And basically, what Healthline got sued for is they were tracking behind the scenes the people that were accessing those specific articles. And the problem here, and this is why like it's really against basic like CCPA regulations and rules and a lot of marketing rules. And I think there's a lot of companies in digital health that don't understand these rules and do them wrong. But if you are having people access your website and you are able to, let's say you have one person who's only reading HIV articles, how to manage HIV, how to deal with HIV, best HIV medications, or little things like that. It's easy to make the assumption that person potentially could have HIV, which is PHI. And so a lot of these telemedicine companies are tracking what people are reading and what people are looking. And this actually passed earlier this year. I know we did a segment on this specifically, but I thought that this really summed it up. Healthline had to pay $1.5 million for violating this in the state of California. And there's a lot of other states that are really adding more and more rules around this. Minnesota, Oregon, Connecticut, they're all following suit because we all know this is a data game and people are sharing
Yeah.
data. And as these healthcare companies, like you actually can't be, you can't be tracking those things. So there's a lot of tools that you're actually supposed to like limit and not use,
That's
but
right. Interesting.
nobody listens.
Did
Yeah.
did they tag them on HIPAA laws or just privacy laws? Do you know?
It was just privacy laws. But again, these have some pretty significant penalties if you look into kind of like some of the rules. And the funny thing is, like, I actually have a tracker on my computer where I can go to any website and I can actually see if they have certain code installed on their website and if they are breaking these rules. And so in my downtime, I will go to
Well
different
done,
companies'
good.
websites and be like, they're violating this and they're violating this and they're violating this. And to me, I think it's interesting how many digital health companies have basically, for lack of better words, given the middle finger to these rules and said, screw it, we are going to just continue to do our pixel tracking regardless of what, is required and allowed by law. And again, I think this is going to be something that is going to be getting even further cracked down upon, especially as these are companies that are actually providing care to people. Whereas like Healthline is a straight up blog, straight up blog.
So that's interesting. And then it goes to the whole like privacy kind of everything, right? That's a big theme right now too. Not just health companies, it's just right what companies are tracking you. Is there any way to other than buying the software that you have, is there any way of turning this off or
Uh,
getting better insight in it?
So the software's free. You can actually get it's just a free software. It's just like a free add-on. And most marketing people have it. So it's not like a normal thing that like normal people would have. But part of it is as so many physicians or operators are working with new telemedicine companies that are just launching, that are just getting in this game, these are normal things that used to be allowed. These are things that were like in standard practice. So if you
Yeah.
have one founder talking to another founder, they're like, oh, sharing their best tips and practices, not understanding the implications of some of these things. And so I have just seen it in my experience over time, even post these rules, that people are still violating it.
Yeah.
It's like something they install on their website. And it's basically a way, like, if anybody has ever visited a website that immediately got like an email or some sort of outreach that was very similar to that website, you're being tracked.
Oh, yeah. No, I had to shut down a whole email address because of it. And I was like, "Oh, I'm done."
Yeah.
Yeah, because it's just mostly spam.
Yeah.
No, it's super interesting.
Yeah, it's horrible. I clicked on one credentialing website and I have 100 voicemails from credentialing companies thinking I'm a doctor needing
Oh,
credentialing. So yeah, again, I think that what's interesting is when people think of compliance, more often than not, my question is my business set up
yeah.
correct? Is my governance structure set up correct? How is my privacy and security? Do I need additional guardrails here? Check my documentation. And I'm always like, what are you doing on marketing? Like, how are you
Yeah.
targeting
Yeah.
people? Where is that information going? Because I think that's just something that people have just often forgot. And it's one of those things, it's a slippery slope. Like nobody wants to get caught doing this. Cause then again, they're gonna dive in and dig into everything else that you're potentially doing.
Yeah, and we've heard horror stories of doctors getting caught into that too, and not knowing what they're getting into, and just, "Hey, I didn't know it was wrong until the med board came after me," and I was like, "Oh, I didn't know what I was talking about." It's tough.
Right. What next topic do you
Alright,
got, Liam?
so talking about states, compact news. So states, the Interstate Medical Licensure Compact, if the IMLC, or people that don't know what this is this compact or this agreement amongst different states that if you get licensed in one of the states involved in this compact, you're allowed to get quickly, basically fast track license into the other states that are involved in this compact. So this is a quick and easy way to get multi-state licensed. And the reasons why states want to do this is, well, hey, everybody knows there's a shortage of doctors everywhere, right? So this just allows doctors from different states to quickly get licensed up into the state, in a different state, and see their patients. And yeah, since the beginning, more and more states are starting up now. And it was just over the past month or so, three more states jumped on board. North Carolina, Nevada, Rhode Island, and California is not part of the compact, but they also introduced legislation which allows doctors from other states to treat Medi-Cal patients. So this is interesting, right? So
Yeah.
access,
So
right?
interesting.
Right?
I loved seeing that being introduced because as somebody who's in California, there's access issues everywhere,
Yeah.
but like California specifically. And so to me, it's, oh yes, more access, more specialists, more care.
And now getting more universal because now, currently, there are about what 40 states in the compact, with three more states are Arkansas, North Carolina, Rhode Island. Legislation just passed, still pending, and states like Massachusetts, New Mexico, New York, even, and North Carolina's been listed twice because it has dual status. But the legislation is introduced in these states. It's just easier to comment on who's not part of the compact: Arkansas, California, Oregon, South Carolina, Virginia, and Puerto Rico, US Virgin Islands as territories. So, yeah, more and more. So, this tells me a few things. One, telemedicine is not going anywhere, it's only growing, right? States are acknowledging that, yes, there's this role, this validates where we think telemedicine is growing, and states are realizing this and are trying to utilize utilize this access, right? They're acknowledging that, yes, there is a need and we need to do it. We need better access. And this is really the only way to go. Good luck trying to convince people to move to that state to improve access, things like that. So they're realizing that, yes, as a telemedicine doctor, it's valuable to have other people see your patients if they live in different states. So that's awesome. So yeah,
Yeah, and I also think too, I think it's global for providers. For nurse practitioners, they also have I don't really track nurse practitioner stuff too close, but I know they have a number of
yeah,
states that they're able to do IMLC.
yeah,
Physician assistants are up to 19 now, and they're having, again, like a slower roll,
yeah.
but it is pretty interesting. All of these states are really trying to make it as easy for physicians and providers to be able to, one, just be clinicians and not have to worry too difficult about, like, the red tape and the barriers.
Yeah.
But I also think they're removing as many potential barriers as possible to make it so that you can work in other states, you can do virtual care, and you can actually, like, work at ease.
Yeah.
One interesting thing tied to this is a lot of these states are also issuing bans on non-compete, which I think is
That's
really
interesting.
interesting. I did a post about it, but there's a number of states, and it's almost like growing by the day, that are issuing these bans on non-competes. California, of course, being the first,
Yeah.
but ultimately, what are they saying there is, "We don't have enough providers, and you're not gonna sell your soul to one,
Yeah.
company. We're not gonna allow that anymore." And so it's just kind of an interesting add-on to the IMLC stuff.
Yeah. No, definitely breaking down barriers. So that's very promising for this market. Yeah, the 50 state licensed doctors, there's going to be more and more. It's just going to be easier. And I think for the better access. And yeah, hopefully we see more doctors, more specialists too, to improve access.
Um, okay, so one other, like, my last big topic, and this is actually, like, hot off the press. Geez Louise, like, this just happened yesterday or the day before. But again, one of the big things this administration is really pushing is, how can we improve interoperability, data sharing, patient navigation? Like, how can we make this whole system, like, so much easier? And this week, the White House, it was interesting. They were doing, like, techie stuff, right? Like, the White House was releasing these, like, plugs and promo videos that they have, like, this amazing update coming around potential innovation. And so this week, they hosted an event that basically says that they are starting an initiative called the CMS Health Tech Ecosystem. And they've tapped the shoulder of about 60 healthcare companies and different tech firms to really start collaborating together to solve this problem. And, like, when I say, like, they tapped tech firms, like, I mean, like, Amazon, Apple, Google, OpenAI, Anthropic, like, big freaking names in this business, to where they can really focus on some, like, core pillars, mainly to just, one, I think, make healthcare a little bit more equitable, but also to just streamline stuff so it's not so clunky.
Yeah, no, this is interesting because further validates health tech, telemedicine, so forth and so on. What I wonder what the 60 companies are. I don't know. But no, that's interesting to see who they tap though. Just quick look, AI, big AI. I think one of the AI gurus is one of the leads of this. So it goes to show one major focus. And really, it's going to be interesting to see what metrics they're tracking as well. Access for sure. And how do they do that and across the board? Yeah.
Yeah. There's a few key issues that they're focusing on. So they're focusing on two main buckets here. Like, one is, like, just basic interoperability, which, I mean, I think for people who don't know what that means, or basic, really, it's like, how can you just continuously share data across systems, across teams, and not have to provide the same information? How can we share care plans? How can we share intake forms? How can we share patient records and patient data versus you having to provide all that information again to providers, health plans, so on and so forth? And again, working across different networks and EHRs and tech platforms to
Yeah.
do that. I think is the one big thing. California, again, has been working on something that they've called the data exchange framework for the past few years. And I think California is really hoping that they'll look at some of their learnings to be able to go, this has worked and this hasn't, to try and like actually make it come to life because it's a big thing. It's a
Oh
huge,
yeah.
huge problem.
Yeah.
And that's why I think it's really cool that the federal government, because my stance has always been if it's not done at the top down, like it's really not
Yeah.
necessarily gonna work.
And you're right. This is a big issue. Working telemedicine companies asking the patient what their history is, and it only goes so far, right? And trying to get the patient's data, trying to get their records. A lot of times, sometimes, most of the times, we're running blind on this. And yeah, this is going to be a good thing for patients, patient care, and just universal get quality, universal quality care across. If we're able to see their chart across multiple systems, EHR, so forth and so on. Yeah, no, I'm looking forward to hopefully this succeeds and looking forward to the operation of this. Yeah, it's just gonna make the job a lot easier just working throughout.
Yeah. And I also think too, like they're also trying to streamline other types of things. So like they're leaning into kind of like apps and digital
Yeah,
services to like, no more like paper forms. Believe it, like people still use paper forms. It's
right,
like,
right.
like, building in more like conversational like AI assistants for like appointment scheduling and care navigation and some of that stuff. And then of course, like really trying to get back onto like prevention and like, you know, quality. And so focusing on like diabetes and obesity management and some of those like key areas. So yeah, I'm again like I'm all for it. Let's see how it goes with all these big names in the same room. Let's see what people can agree on.
A lot of cooks in the kitchen there, though. We'll see. We'll see what happens.
Just a few big personalities, I assume.
Oh man. But no, hoping this one goes through actually. Because again, yeah, this would be great for patient care. Um, so my next story is this telehealth kiosk pilot program in this small Texas county, Webb County. And it involves this small area that has 800 people in the population and really no full-time doctors in their community. So access, I was reading up and access, the closest full-time doctor is about an hour away. And this is in Bruni, Texas. And what happened is this company, One Med Care Station, basically created kiosk, this virtual health kiosk with this big old touch screen that's very intuitive and interactive. And patients go into this booth and are seen by medical providers in this kiosk. And the initial response is very positive. People are going in, and instead of traveling an hour away to see somebody, they could pop in this little booth and get seen. And I think this is a positive sign. One of my big positives in telemedicine is, hey, we could reach out into these communities that don't have access themselves. And right now, I think it's just this is primary care, acute care. The possibilities are endless. You could reach out to specialty care, and this kiosk has like a full body screen, right? Instead of this kind of face to face and things cut off, the patients are actually like standing full body, and you could actually see. So, a better virtual kind of exam as much as you can, right? But a better virtual exam because you could see the entire person. And this the cost of this residence is actually free, right? Subsidized by a big insurance company, for better for worse. So yeah, and they're trying to expand. They're trying to expand to more areas without access. And yeah, it'd be interesting to see how far this goes. It's looking like they're going to other parts of East and South Texas where again access is limited, where you have to go. Texas is huge, right? You have to go far out just to get somewhere. Yeah, so check it out, check out the story, and check out the website. It's One Med Care Station, and it's cool. Its technology's there. And yeah, you can almost
Yeah.
it looks like one of those like privacy booths in like the airports and whatnot. And yeah, it's just you just duck in and there's like an occupied sign. It's almost like one big mobile lavatory almost. It
Yeah.
turns red and whatnot. It's pretty interesting, I thought.
Yeah, I am surprised that they haven't piloted more of these, given I think, like you had said, like, it is funded by a large payer, but, like, it isn't every payer's best interest to have people go to the
Absolutely.
doctor and get,
Yeah.
like, preventative
Yeah.
care, and so, for me, I think one of the interesting things of, like, when I was working on some of my public health initiatives, how many people actually don't understand how to use any sort of technology mixed in with healthcare.
Yes.
And so part of it is I think it's just interesting that you're giving people the opportunity to like, one, not just see a provider, but also if you don't have the right technology to be able to do it at home, which I mean, I live in a populated area like Leo, like you live in paradise. I think that piece of it is, yeah, we forget that these rural communities also don't quite understand how to effectively like use telemedicine as it is.
No, that's actually a great point. I'm glad you made it, because one of the big speed bumps, one of the big inhibitors of expansion of telemedicine is this technology access, or not just access, but technology knowledge. I remember talking to this one telemedicine company that was trying to expand into reservations and native populations, and it wasn't the lack of need, but it was just the lack of, one, high speed internet access, and two, just knowledge of how to use the technology. So yeah, I think this is great. It's bridging that gap. So people don't have to figure out how to get access because it's just given to them. And they don't have to figure out how to set up their computer, their cameras, especially in the older population. That's part of the problem is they just can't do the video consult because they can't just figure it out. And we get that story a lot from current telemedicine providers. No, that's a good point, is that, yes, they basically spoon feed the technology and the access, making it more accessible too. So not just location, actually giving them the tools to do so.
Yeah, I would be interested to see, like, the utilization data around it, and has there been uptick?
Yeah.
I
Oh.
have, like, forever wanted to use, like, vending machines as a way to, like, further increase like, I think, like, in my dream like, if I was, like, a multimillionaire, like, I would have, like, like, I would have, like, vending machines on every single corner with, like, over-the-counter birth control and
Right.
condoms and all the things that I think people, especially either, like, you're in a rural place or you're in a, like, lower income, like, that you struggle, like, to me, I think this is the future of where we're going, and I think it's really cool.
Just imagine
Um
if pharmacies get into this too and like instill like a vending pharmacy in this. And yeah, the doctor prescribes it, and common drugs, their antihypertensive pills just get vended right there. That would be interesting.
Yeah, I would be surprised, like, I would be surprised, like, it's almost like they should tie these to a pharmacy or something. I don't know if there's local pharmacies there or not, like, how that
Right.
works. Again, like, that's something I've seen in rural communities of, like, actually the pharmacy was more of the, like, care station than
Yeah.
an
Yeah.
actual hospital or office because you have a pharmacy and a Rite Aid or something,
Yeah.
and so they would actually, like, really try to, like, closely tie because I think there were more access to pharmacies, but yeah, again, there's so much you can do with this, especially, like, when it comes to the follow-up care that's needed. It'll be interesting to see how successful it is.
Yeah. No, it'd be interesting to get a follow up on this. Maybe what, like half a year down the line, and see how this pans out. So no, that'd be fun to see.
Yeah.
Cool. That's all I got in terms of this month's kind of wrap up. Anything else?
No, yeah, like I said, I did a post about it. Y'all can check out my Instagram if you are interested. But yeah, for the most part, still lots coming out on federal government stuff. I didn't wanna bore everybody with another one about my Medicare, Medicaid, but there's a lot of implications, like, in some of those things. One topic that I was gonna bring up, but it's really not relevant at all, but I thought it was really interesting, and I don't know, maybe, Leo, we can get your perspective, is, like, how in the One Big Beautiful Bill, they did cap student loans and how that could or how that is going
Yeah.
to impact the future of medical students and who actually goes to medical school and who doesn't. Um,
Yes. Yeah. Actually, that was a big issue. I've seen articles on that saying that, yeah, yeah, we should talk about that more because that's an interesting topic.
yeah, maybe we could talk about that next time,
Yeah.
but that was one thing that I was like, again, coming from somebody who is completely self-made, I I would not have been able to fund medical school myself, and it'll be interesting to see, like, is the doctor shortage going to get worse? And I think the answer is probably
Oh,
yes.
absolutely. Absolutely. I think it will. I think it will, especially also the view on medical school and being a doctor nowadays, right? And the challenges and the burnout and this and that. So, yeah, we're going to see the shortage just get worse and this access issue become more prevalent.
Yep.
Yeah. For those out there listening, if you have any great ideas or topics you want us to talk about or research, or you thought, hey, this was cool, just drop us a line, info@telemedicinetalks.com. And our personal contacts are leo@telemedicinetalks.com and phoebe@telemedicinetalks.com. Pretty simple. Definitely subscribe, and we will see you again next time.
Ciao.
Aloha.